Hi, my name is Dr. Imran Khawaja. I'm a sleep medicine physician and a psychiatrist. Today I will be talking about sleep disorders. In this talk, you will learn about various sleep disorders, let's start by talking about how Americans are getting less and less sleep, and you see that the results are quite obvious. Sleep problems have become extremely common. In your clinical practice, either you are a psychiatrist, psychologist, social worker, primary care physician, or an internist. You must be seeing that sleep problems are becoming extremely common. As a primary care or mental health provider, you are the first person to recognize these sleep disorders. You are the one who see these patients on a regular basis. You're the one who treat them in the first places. So it's important that you know about sleep disorders and are able to screen patients with sleep disorders. In addition to that, there is more and more literature coming out talking about different issues. For example, insomnia is known to affect various body functions. We are finding out that it affects weight, can affect the blood pressure, increases the risk for heart disease and even diabetes. It affects the immune system. More and more studies are coming out suggesting that insomnia and sleep disturbance is a risk factor for many mental health problems like post-traumatic stress disorder, depression, anxiety. If you are able to address sleep in your patients and able to ask questions about sleep, you will likely improve quality of your life of your patients. Let me ask you these questions to start with. In your practice, if you are not a sleep physician, diagnosing and treatment of most sleep disorders is either extremely difficult and should not be attempted, manageable with good knowledge about sleep disorders, always requires complicated testing for every patient, or is it unrelated to your practice? I know you all must have guessed it right. The answer to this question is it is manageable. Manageable with good knowledge about sleep disorders. This is what our goal is in this presentation, to help you recognize sleep disorders, manage them, and refer them appropriately when is needed. There are three objectives for this presentation. You should be able to state three common sleep-related clinical complaints. Should be able to obtain basic clinical history which will enable you to either treat or refer patients. So let's begin. There will be total three parts to this presentation. The first will be review of sleep. Then we'll talk about approach to a patient with sleep complaints. You learn about these three clinical chief complaints, and then we'll conclude. Sleep. What is sleep? This has been a mysterious question all along. For ages and ages, different people have thought differently about sleep. For example, Freud called sleep as a safety valve. Some people think that sleep is necessary. Over the years, we have found that sleep is indeed quite important. So, let me ask you another question. Sleep is a complex process. Is it active process, or is it a passive process, or is it both? Answer to that question is sleep is an active process. What happens in sleep? There are three states of being. Either you are awake or you are in these two stages of sleep. When you are awake, your brains are active, bodies are active, and you have an external orientation, meaning that you are looking at what's going on outside. However, when you are in REM sleep, your brain is highly active, metabolically very active. Your body is paralyzed and you are dreaming, so you have an internal orientation. In non-REM sleep, the brains are somewhat relaxed, but they're still active. Bodies are relaxed, they are not paralyzed, like in REM sleep, and you have an internal orientation. When a person goes to sleep, they fall asleep, they go through stage N1, which is non-REM sleep, then stage N2 and 3, and then they go into REM sleep. This one cycle of going from stage 1, 2, 3 and to REM sleep is called a sleep cycle. A person throughout the night goes through several 4 to 5 of these sleep cycles. As you might have noticed that the REM sleep here keeps on getting bigger. That is why when you wake up in the morning, most likely you are waking up from the REM sleep and you remember your dreams. As we grow older, sleep requirements decrease. For example, a baby needs 16 to 18 hours of sleep, whereas adults need between 6 to 8 hours of sleep. Let me have you understand this concept of sleep debt. We develop sleep debt just like any debt. A person whose sleep need is 8 hours and he or she is getting 6 hours, they are accumulating sleep debt. So every day the sleep debt starts growing up if they're not getting enough sleep, and say on the weekends the sleep debt is so much that they cannot take it anymore and they fall asleep. Looking at this study, which was a study back in 2003 done on people who are quite healthy, to explain what sleep debt is, they had 3 different groups of people. All of them were adults. They were asked to sleep different hours. For example, the first group was asked to sleep 8 hours in bed, total time 8 hours. The second, 6 hours, and the third group was asked to be in bed for 4 hours only. As the time goes on, for example here, the days are going, you see that the group which were getting less than 8 hours of sleep, they started to go into the zone of impaired performance. These people started having lapses of performances. You can see this. So these lapses of performance were almost equal to being awake 40 to 64 hours at a stretch. And surprisingly, these people said that they don't feel sleepy as much, but they were still able to perform poorly cognitively. So we have talked about sleep. Let's discuss how to approach patients with sleep complaints. In this section, you will learn about clinical history taking, asking about what patients should tell you about their sleep patterns. Approach to patients with sleep complaints. It's like taking any other history in clinical field, either psychiatric history or medical history. But in this, we can use some tools. You can use tools like sleep diary. Of course, you can refer patients for sleep studies. But sleep history is generally like detective work, just like any clinical history taking. You want to learn about their regular life, not just their sleep hours. You want to learn about their 24 hours. You want to know information from collateral history, for example, their spouses. In my clinical practice, multiple times it happens that the patient is telling me that they do certain things. For example, they don't drink coffee, or they don't snore, or they're not sleepy. But when I look at the spouse is rolling his or her eyes. So collateral information is very important when we are taking sleep history. Lifestyle history, psychiatric, medical issues, and of course medications are extremely important. Getting information about medications is extremely important. Sleep diary is a useful tool, and I give this to the patients. It's very helpful because, first of all, it gives you an idea whether the patient is willing to work with you or not. It facilitates alliance with these patients. Dr. Hari from the Mayo Clinic used to say that you want to make your patient his or her own sleep doctor. So you have to get help from your own patients. If they are not going to work with you, it will not work. No matter what you suggest, they are not going to follow that. Moving on to 3 main sleep complaints. You will learn in this section that there are only 3 chief complaints as far as sleep is concerned. You will learn about these 3 complaints, and once you learn about these 3 complaints, this will lead you to understand what different sleep disorders could be causing these 3 chief complaints. So, the first sleep complaint is, you can get a patient who comes to your office and says, "Doctor, I am sleepy." Or the spouse says that my husband or wife cannot stay awake. When they are driving, I am concerned. That is complaint number 1. This is a very common complaint. Other complaint is that the patient might come and say, "Doctor, I cannot fall asleep. I cannot stay asleep. I wake up multiple times in the middle of the night. I don't know what to do. When I get up in the morning, I feel unrefreshed. I have been having this problem for many, many years." That is complaint number 2. Complaint number 3, the patient might say, "Doctor, I move a lot. I act my dreams. I get up and do things and I don't remember." Or the spouse might say, "Doctor, my husband kicks during his sleep. He is restless throughout the sleep. He's tossing and turning. He's punching and kicking. Often he gets up." That is patient with excessive movements during sleep or before sleep. So first, we'll talk about a patient who is very sleepy. Okay? This is one of the most common complaints you are going to get in your practice. These are the different sleep disorders which could be causing your patient to be sleepy. Number 1 on the list is, of course, sleep disordered breathing, obstructive sleep apnea. Number 2 is intrinsic hypersomnias or narcolepsy. Then, this one is very important. I have had so many patients in my practice who had complaints of sleepiness, but when you get detailed clinical history, you find out that they are not sleeping enough. Their lives are busy. They cannot have enough time to sleep. They are doing 2 or 3 jobs. That's why it's important to know that. Then medical and psychiatric history. Several medications could possibly cause daytime sleepiness. Let's learn about sleep disordered breathing. Most of you have heard about obstructive sleep apnea or known somebody who has sleep apnea and uses CPAP machine. So what happens in obstructive sleep apnea? Before we learn about that, let me ask you one question. Just in the Veterans Affairs system, in the VA system, sleep apnea payments or compensation from 2008 to 2010 increased by 10%, 25%, 50%, or remained the same? The answer to that question is that it increased by 50%. So more and more people are having obstructive sleep apnea. If you look at this, from 2008 to 2010, the payments went up almost double. Now, snoring disrupts the partner. We do know that. If you do not, you can watch this video on the YouTube. Now, let me present you a case of a patient who had obstructive sleep apnea, but his chief complaint was not that he has sleep apnea or he was sleepy. Of course, he was sleepy, but that was not his chief complaint. He's a 63-year-old male who was referred because he was having nightmares. And he was having nightmares because he was a Vietnam-era veteran who, whenever would be on his back, would start having nightmares. It turns out that he was also a tunnel rat, in which means that he was in Vietnam and he would go into the tunnels, would try to find out any bombs and defuse them. Now, the nightmares he was having was from his post-traumatic stress disorder of reliving these dreams in which he would find himself in these tunnels and would not be able to breathe, especially if he is on his back. So what was going on was that whenever he would be on his back and whenever he would be in REM sleep, that is when he was having these dreams, his muscles would all collapse. Remember from our slide, in REM sleep, muscles are paralyzed. So he would stop breathing and he would wake up with the feeling of not being able to breathe, and he would be dreaming that his tunnel is falling apart. So this is what happens in obstructive sleep apnea. In a normal airway, air goes in through the nose, behind the tongue, behind the structure, into the lungs. So this opening is well open. Whereas in people who have obstructive sleep apnea, air goes in, this area seems crowded, air goes in, hits this obstruction, swirls around and causes snoring. So whenever you find that your patient is snoring, there is a chance that he or she might have obstructive sleep apnea. Not everybody who snores have obstructive sleep apnea. What are the signs and symptoms you are concerned about when you are thinking about obstructive sleep apnea? What you want to ask about is whether your patient snores or not. If snoring is worse on their backs, because the tongue tends to block that. If the spouse tells you that yes, the husband or wife stops breathing. If they have apneas, meaning cessation of breath, they have higher chance of obstructive sleep apnea. What are the other screening questions? There's a questionnaire called STOP questionnaire, which stands for S as for snoring, T for feeling tired, O for observed apneas, and P for high blood pressure. This question, if positive for all these four parts, yields a very high sensitivity. You can ask that in your clinical practice. Also, you can ask your patients to open up their mouth. If they open up their mouth and they stick their tongue, and you can see this opening, this uvula, then it's called Melon-Petty 1 or A. Here you could see half of it. Here you can see hardly anything. Here you cannot see anything. People who have crowded airways have higher chance of obstructive sleep apnea. In addition to that, you can measure their neck circumference. For men, if it's more than 17 inches, for women, if more than 16 inches, it increases their risk. BMI correlates with sleep apnea. Higher the BMI, more chances of obstructive sleep apnea. Obstructive sleep apnea patients tend to have higher psychiatric disorders. This was a study out of VA Medical Center, Michael E. DeBakey VA Medical Center in Houston. More than 100,000 veterans' charts were reviewed. Veterans who had obstructive sleep apnea tend to have higher percentage of depressive symptoms, anxiety symptoms, and PTSD. Now, in Pakistan, maybe you or other countries, you don't see patients who have using CPAP machines, whereas in the US, there are many patients who are using CPAP. If you don't ask your patient whether they are using CPAP or not, they are not going to tell you. Remember, using CPAP is not very attractive. People don't like to use it unless they get comfortable with it or they start noticing that it helps them. It often is not considered as an attractive option unless the spouse makes them wear it because they don't snore on it. When your patients are saying that they cannot use the CPAP, the first thing you can ask them to do is educate them that obstructive sleep apnea might be contributing to their mental health condition, might be contributing to their high blood pressure. You can also ask them whether their mask fits or not, because most often the mask is not the right one for them. So if they get a new mask which fits them better, there is a higher probability that they'll use it. Moreover, you can ask them if they're using it with heated humidification. In each CPAPs nowadays, there is a humidifier which helps to maintain the humidification of the air which they're getting. Let's move on to another question. There is no overlap between symptoms of depression and symptoms of obstructive sleep apnea. Is it true or false? I would say it's false. Looking at common overlapping symptoms between obstructive sleep apnea and depression. If you look at obstructive sleep apnea, there's snore, there are witnessed apneas, and snort arousals. Depression, sadness, anhedonia, agitation, guilt, weight loss. But look at all these other symptoms. Sleepiness, loss of energy, poor concentration, irritability, psychomotor retardation, weight gain. These are all common symptoms of depression and obstructive sleep apnea. Now we will talk about sleepy patients' next category, which is narcolepsy. You learn about narcolepsy in this section. Again, you learn about a case of a person who was recently diagnosed with narcolepsy. This was a patient in my practice who was a young veteran, was returning from service, no history of combat as such, does not have post-traumatic stress disorder, comes and tells me that, doctor, I feel tired all the time. I am a pharmacy student, but when I am in the class, I cannot stay awake. There's got to be something wrong with me. we did the sleep study, he did not have any sleep apnea. But when we did the nap studies, which are also called as MSLT for multiple sleep latency tests, it showed that he was falling asleep very quickly. He also was developing symptoms of cataplexy, which is, by the way, episodes in which people tend to lose their muscle tone due to emotional stimulus. For example, patients who have cataplexy will laugh and suddenly would lose their muscle tone. Either they'll drop things or fall down onto the ground. They may not necessarily fall asleep, but this is generally triggered by laughter, but it could also be triggered by other emotions. For example, another patient of mine said, at some point my friends discovered that I would collapse when I laughed. They invented a game called Flooring Zack, in which they took turns telling jokes. The jokes that made me fall to the ground won the game. This could be quite debilitating as well. People who have narcolepsy have symptoms of excessive daytime sleepiness. So that is a given. All of the patients will have excessive daytime symptoms. Cataplexy is present between 60 to 70% of the patients. Hypnagogic hallucinations, meaning they will start having some hallucinations when they're falling asleep, or see images when they're falling asleep, is present, but this could be a normal phenomenon. Sleep paralysis means that they're falling asleep or waking up from sleep, but they can't move their body for a few minutes, and that could be quite normal. Patients who have narcolepsy have fragmented sleep. Their nighttime sleep is fragmented. Narcolepsy patients have to have better choices when it comes to their carriers. A lot of states in the US don't allow patients with narcolepsy to be able to get commercial driver's license or airplane licenses. When they have to do rotating shifts, they're extremely difficult for them to do. Working with dangerous equipments, which is dangerous anyways, could be more so with patients who have narcolepsy. Now, I remember treating a patient who was a physician and doing his residency, and he was not diagnosed with narcolepsy, but then when we did the study, he was so sleepy, he had narcolepsy. This guy could not function because whenever he had to do night shift or go back and forth, he could not function. He would fall asleep taking history of patients. I had to write a letter to his program director so that he should not be put on rotating shifts based on the diagnosis of narcolepsy. What are the treatments of narcolepsy? In primary care as primary care physicians or psychiatrists, you must have used these medications. These stimulant medications are used to keep people more alert. Modafinil, Ritalin, amphetamine salts are all quite helpful. So we have covered narcolepsy. Now we will move on to discuss other conditions or issues which could cause excessive daytime sleepiness, but we will treat them together. For example, the last three topics: inadequate sleep, medical psychiatric disorders, and medications. They can all cause your patients to be sleepy. Now, inadequate sleep is one of the most common causes. It is actually a diagnosis as well. In our society, our lives are busy with homework, with entertainment, and we do not have enough time to give to our sleep, and that could be the number one reason. Many medical and psychiatric disorders, for example, depression could cause sleepiness, congestive heart failure, Parkinson's disease, seizure disorders, and different medications, for example, benzos, trazodone, antidepressants, which could cause sleepiness, antipsychotic medications. So now we have completed our chief complaint number 1, which is of a sleepy patient. We've covered the conditions which could possibly cause that. We'll move on to our next chief complaint, which is patient who cannot fall asleep or cannot stay asleep. These are the conditions which could cause patients to have difficulty with inability to falling asleep or staying asleep. Number 1 is insomnia, which is very common. Delayed sleep phase syndrome, will discuss some circadian rhythm sleep disorders. Then psychiatric disorders, medical disorders, and of course medications. Insomnia is when a person comes and complains that he or she cannot fall asleep, he or she cannot stay asleep, or wakes up early in the morning, or the quality of sleep is extremely poor. Insomnia could cause them to feel tired during the daytime. Patients could complain that they are fatigued, they are irritable, they cannot concentrate at work. They are concerned about insomnia, they are worrying about it. In the industrialized nations, 30 to 40% had complaints of insomnia at some point. It's more common in women, just like depression. In elderly, of course, elderly patients have more medical problems, their sleep gets more fragmented, they complain of insomnia a lot. In addition to that, what happens in elderly patients are that they lose their structure in life. They used to work, but they don't work anymore. They have time all the time. They could sleep, take naps during the daytime, which often affects their sleep at night. Psychiatric disorders, of course, are more at risk. Insomnia has been traditionally divided into secondary insomnia or primary insomnia. But more recently, in the last 6 to 7 years, instead of secondary insomnia, it is encouraged that clinicians use the term comorbid insomnia. Because if somebody is using the term secondary insomnia, it means that it is due to a primary condition, and if you treat primary condition, this will go away. Whereas that's not the case. It somehow encourages under-treatment and under-recognition of insomnia. Comorbid means that these two conditions are present simultaneously and needed treatment and attention together simultaneously. For example, in studies in clinical depression and insomnia, people have found out that if insomnia is not treated, depression does get better, but insomnia remains as a residual symptom. Whereas if depression is treated and insomnia is treated simultaneously, either with medications or with behavioral therapies for insomnia, the depression goes away earlier and quicker, and insomnia goes away as well, and it has better outcomes. What happens in people who have conditional insomnia or psychophysiological insomnia? I like to give examples of the Pavlov's dogs, in which Pavlov's dog were conditioned. So this scientist Pavlov used to give food to his dogs, and at the same time would ring bells. So it was conditioned that whenever the dogs could get food, the bells would be ringing at the same time. After some times, he just started ringing the bell without the food, without the fact that it was the time to get food. And just with ringing the bell, the dog started salivating because the response got conditioned. This is exactly what happens in people who have conditioned or psychophysiological insomnia. Something happens like any kind of stress and they start having trouble with insomnia, but then they're in their bedroom, that gets conditioned that when they're in their bedroom, their brains are active, their minds are active. So even though the stressor goes away, this response gets conditioned. So whenever they go into the bedroom the next time, they find themselves with highly active brains. Their brains are now conditioned that in their bedrooms, they are highly anxious or more alert. Quite often, People who have difficulty falling asleep, they get more and more frustrated and they develop fear of sleeplessness. This can tend to make things worse, and they can have physiological activation. They try to promote sleep, that maybe go to their living room, watch TV, but that doesn't help. So it becomes a cycle. There are several non-pharmacological treatments for insomnia. For example, sleep hygiene, which includes things like not drinking coffee after 3 p.m., keeping the routine same, not taking naps. Whereas stimulus control is when you tell patients that sleep is only to be in their bedrooms. And we'll learn more about it in the next few slides. So let's see what insomnics do wrong. We talk about that. They're sleeping, watching television, doing work, active work in their bedrooms, drinking coffee, for example, taking naps, for example. This gentleman is drinking coffee at night, watching television. Of course, he's going to have insomnia. Sleep hygiene alone does not work. Let's learn about this behavioral prescription called stimulus control, in which you tell your patients to use their bedroom only for sleep or sex. Go to their bedroom only when they're sleepy. Get out of their bed when unable to fall asleep. Do not watch the clock. Wake up at consistent time, including the weekends, and do not take naps. The whole idea is that you are retraining their brains that in their bedrooms, instead of feeling more active in their brains, they'd feel tired. So you're reinforcing that being in bed equals sleeping. And you can tell your patients that I want to train your mind that whenever you are in your bedroom, your brains are sleepy. Right now, since you have insomnia, you go into your bedrooms. As soon as you go in, your brain gets more active, you're thinking about things, and then you're spending time in your bedroom and you're making it worse. So we want to stop that association. We want the association that I'm in bed, I'm sleepy. And the only way you could do it is that you do not spend any time in your bedroom other than when you are sleeping. Different medications are used. For example, benzodiazepine medications, the Z drugs, antidepressants, antihistamines, melatonin, and other medications. So list of some benzodiazepine medications: temazepam, clonazepam, lorazepam. These are the Z drugs. Zolpidem, zaleplon, azopiclone. Many side effects: impaired psychomotor functions, risk of dependence, memory impairment, sleepwalking. I had a patient I just saw a few months ago who was accompanied by her husband. This woman, when I saw her in the waiting room, she had a big black eye, and I was concerned about it. And I thought to myself, maybe this woman was beaten up, maybe it's a case of domestic violence. So I took her into my office. Her husband, who was a big gentleman, accompanied her as well. And when I asked her, she told me that she has been having trouble with insomnia. She went to her doctor, who put her on trazodone. It did not help. This woman was quite big and has a history of snoring, and when I gathered more information, it turned out that she tends to choke when she's sleeping, and this wakes her up multiple times. She told me that she was given zolpidem and she had an episode of sleepwalking and bumped into the door and had this black eye. So sleepwalking is quite common with patients taking Ambien. Now what happens, there are several medications. Another patient I saw recently who had complaints of insomnia, and when we took some chronological history, it turns out that she was started on steroids for her asthma, and that's what caused her to have extreme insomnia. She was also put on some albuterol, which made the insomnia worse as well. Beta blockers sometimes can cause insomnia. stimulant medications can cause insomnia. So let's move on. We are still talking about patients who cannot sleep. We've covered insomnia complaints. Now we will talk about circadian rhythm disorders. Now you learn about the delayed sleep phase syndrome in this part of the presentation. However, we are not going to be talking about other circadian rhythm disorders, which include jet lag, which includes shift work, and because these disorders could cause both sleepiness and insomnia. In delayed sleep phase syndrome, what happens is that a normal person, for example, has a tendency to sleep, say, from 10 to 6 or 7. With people who have delayed sleep, their sleep time is delayed. So their natural time to sleep is around 3 a.m. They like to wake up more at noon time or later. These are the people who are also called as night owls, quite common in adolescents. They complain of sleepiness when they wake up early, when they have to go to school. They complain of insomnia here. The treatment is that they can be given some melatonin 4 to 5 hours before their desired time. Also, we can expose them to bright light when they wake up in the morning. It's quite underdiagnosed, especially in adolescent population. In elderly patients, especially the ones who are in nursing homes, tend to have poor circadian rhythms. Now, circadian rhythms are governed by suprachiasmatic nucleus. If there is some degeneration going on, that suprachiasmatic nucleus tends to have some degeneration, which then cannot generate our body rhythms well. So sleep rhythms are included in that. As a result, people have poor fragmented sleep. Moreover, they are in nursing homes. As you see in this picture, they don't have much of light. They don't get exposed to light. They are not active. They're taking naps during the daytime. It disrupts their sleep-wake patterns. Now we've covered two main chief complaints. We've covered patient coming to you saying that he or she is sleepy. We have covered the complaint of patients who comes to you and says that he or she cannot fall asleep or stay asleep. Now we are moving on to the last complaint, which is patient having excessive movements during sleep or before sleep. Now what could be the disorders under this category? There's a group of disorders called parasomnias, which means that parasomnia means events occurring with sleep. Abnormal physiological behavioral events occurring with sleep. If they are coming out of REM parasomnias, it's REM sleep, it's called REM parasomnias. If they're coming out of non-REM sleep, they're called as non-REM parasomnia. The post-traumatic stress disorder has some nocturnal events related to it, but usually a person does not move. I have put it there because I would like you to know a bit about post-traumatic stress disorder related sleep issues. And then person who has restless leg syndrome could be in this category as well. So parasomnias, in REM parasomnias, for example, REM behavior disorder is one. You learn a bit more about it. It's a very important disorder, can be dangerous, and then nightmares. In non-REM parasomnias, sleepwalking and night terrors are the two main examples. It can also include confusional arousals. This is a patient who had REM behavior disorder. And his complaint was that he used to hit his wife. He would start acting out his dreams. This is a video. I'll not be able to play the video. However, in patients who have REM behavior disorder, when they're having a dream, they start acting out their dreams. So this gentleman is punching and kicking, and often he'd kick and punch his wife. The reason for that is that this disorder is associated with Parkinson's disease, and there are certain areas in pons which get affected. And pons is the area which is responsible in REM sleep to keep our muscles paralyzed. And if there's something wrong over there, that mechanism is broken, and a person starts acting out dreams, because that's not normal. Remember, when we are in REM sleep, our muscles are paralyzed. In REM behavior disorder, that mechanism is broken. Once patients are diagnosed with it, we educate them about the possibility of developing Parkinson's disease, and of course they feel sad about it. And 90% or more of these patients tend to develop Parkinson's disease. Disorder is more common in men for some reason. What do you do with patients who have REM behavior disorder? Of course, you want to avoid injuries. I've had patients who have injured themselves severely. I just saw a patient recently who was having a dream that he was in Vietnam and he was being attacked and he was running. Suddenly, he found himself on top of a rail car, and he heard the Viet Congs coming, following him, and he kicked one of them. But then, in actuality, since he was dreaming and sleeping, he kicked his wife and fell down and broke his ribs. So you want to avoid injury, you want to remove sharp objects. The medication which works the best is clonazepam or Klonopin. 0.5 milligrams to 2 milligrams, depending on how much they can tolerate. In addition to that, melatonin can be used. These patients should have neurological exam once a year so that we can pick up any Parkinsonian symptoms. Moving on to the non-REM parasomnias. Non-REM parasomnias are also known as disorders of arousal. This also includes confusional arousal, which is kind of sleepwalking, but in this, the patients do not get up and walk around, they look around in their bed. How do you differentiate between REM behavior disorder and sleepwalking? In REM behavior disorder, a person is acting out their dreams. Generally, they stay in their bed. Once they wake up, they remember the dream. Their eyes are closed when they're doing that. Whereas in sleepwalking, people do not remember what they did. They might get up, they can do more complex behaviors like getting up, walking around, going to the kitchen, making breakfast or something and not remembering it. Treatment of non-REM parasomnias also includes clonazepam, which is quite active, and also reassurance. Kids who have sleepwalking tend to grow out of that. A last topic of the day, which is still under the category. Now, we have covered sleep, we have reviewed functions of sleep, we have reviewed assessment of patients with sleep complaints, then we reviewed 3 chief complaints. Number 1 was sleepy patients. We reviewed what are the different disorders which could cause sleepiness. We covered complaint of insomnias, not being able to sleep, which included insomnia, circadian rhythm disorders. Now we are talking about the 3rd chief complaint, which is excessive movement during sleep. We've covered the parasomnias, which included REM behavior disorder or REM parasomnias, and we have covered non-REM parasomnias, including sleepwalking and night terrors. Now we are talking about restless legs and periodic limb movement. Let's talk about this question. A 65-year-old woman presents with leg discomfort. She can't sit still in the early evening while watching TV and must walk around. She's told that her legs twitch at night. She does not snore, no witnessed apneas. What's the most likely diagnosis? Is it restless legs, periodic limb movements. She has restless legs syndrome. Now, you can remember it from this mnemonic. There are four main symptoms. Urge. Remember the mnemonic urge. U stands for urge to move legs. R for resting, that is, it's worse during the rest. G is gets better if walking and movement. And E for evening, symptoms are worse in the evening. Very common disorder, more so in women, less common in minorities. This is how several people describe it. Some common mimics like peripheral neuropathy can mimic it, varicose veins. Treatment, nightly treatment, dopamine agonist, you can use hypnotic, but mostly dopamine medications like pramipexole or ropinirole. Common syndrome, we talked about four criterias. History and physical is important. One thing I would like to mention is that we can check the ferritin levels, because sometimes ferritin levels are low, and if you replace it with iron, symptoms improve. We have covered almost all sleep disorders, including three main complaints. I'd like to conclude by saying that sleep disorders are often common. You are seeing these patients. These patients or these complaints are often missed. Sleep disorders are quite comorbid with multiple medical and psychiatric disorders. And if sleep is better, the patient's quality of life gets better. We like to take history from the bed partner if possible. And as mentioned, if we can improve the quality of sleep of our patients, that's 1/3 of their life, and it improves the quality of their life as well. I will stop here. Thank you so much.